Welcome back to Medical Experts in Football. I'm Tyrell, the host, a physical therapist, and journalist. And today we have a special guest that comes right from good old ATL, Atlanta, Georgia in America.
When I look back, when it's not the convenient thing to do, when it's not the comfortable thing to do, that's why I do it. I think medicine is just it's just part of who I am. Meaning, who I am should exude regardless of what else I do.
And here's Dr. Olufade, a board-certified physician in orthopedics and sports medicine. He's also the Assistant Professor of Orthopedics at Emory. Other various roles, he also serves for several athletic teams, including U.S. Soccer, Atlanta Hawks in the NBA, and Emory University and some high schools in the Atlanta region. So you are in Georgia. I'm also in Georgia. It's a state in the South known as a peach state. Have you had one of Georgia peaches before?
Of course I have. I enjoyed it.
Okay.
It was good. It was really good.
Yeah, I have not. Now, if you would describe Atlanta in one word, what word would that be?
Ooh, gotta think about that one. One word describe.
One word.
I will call Atlanta.
Wow, it's really that hard?
Yeah. I'm very picky with my words. Uh,
Oh, okay.
I
We got a
think
picky doctor here.
a little bit. I will call it original.
Original. And what do you mean?
So I think folks that even though the line is most people that live in Atlanta right now are not from Atlanta because there's been a lot
Mhm.
of people that moved out here. I think there's a little bit of authenticity to what they're about, what they stand for. They're not afraid to show who they really are and what their personality is. I think the
Yeah.
authenticity and originality of that is where I'm coming from.
Okay. I haven't been in Atlanta long enough, but I would say from my observation, I would say diverse because I feel like I see people from all over, which is pretty cool. Well, speaking of Atlanta, Atlanta Hartsfield Airport is known as a high traffic airport. It's, I think, the busiest airport in the world. So, I mean, if I have an airport or if I have a flight that's like at 9 o'clock, getting there at 6 p.m. for me, that's like on time. Like I'm not going to miss my flight. Now, Atlanta traffic is also on another level. How can one keep their cool while driving through Atlanta's highway?
Yeah, that's a tough one. You just for me, I'm a guy that actually really early. If I get somewhere on time, that means I'm.
Hmm.
So I think one is just punctuality, leaving ahead of time. That way we get stuck in traffic. I think listen to podcasts, listen to whatever you like outside of the driving. I think that will also help for me. I tend to listen
Yeah.
to a lot of music because I do a lot of talking in clinic and I do some talking at home as well too. So I
Yeah.
think for me it's just kind of an opportunity to listen to music, sometimes sports shows. That's kind
Okay.
of what I do a lot of my time, and you just have to be patient because there's going to be traffic and we could work on the driving a little bit in the state of Georgia and Atlanta.
Absolutely.
I'm a little bit biased, so it's okay.
You said the word patience, which is why I stay away from Atlanta because I don't have that patience to deal with that traffic. Well, just a trivia question for you because you've been in Georgia for quite some time. Georgia grows the most of what food in the United States?
I'm just gonna say peaches.
Peanuts. I thought you were actually going to get it.
Yeah.
Peanuts. They grow the most peanuts. So if you're in Georgia, I'm not a fan of peanuts, try the peanuts. Now, finally, for guests that have not been to Georgia, what are some cool places you would recommend them to visit in Atlanta?
Yeah, I remember when I first came here, I went to the typical places. They have a Coca-Cola a big setup that you'll go to. So that's
Mhm.
in town. It's always fun. We
Uh-huh.
actually have one of the biggest zoos that's available as well too. When you go to other places, you just ask yourself, that's it? So I
Yeah.
think from a tourist standpoint, checking out those places are good. For me, I like restaurants. I like good vibes. So I've kind of checked out a few restaurants. Like I mentioned, speaking of diversity, if you drive on Buford Highway, I think
Mhm.
that's where the diversity comes in. I went to a Korean restaurant yesterday, a barbecue restaurant. It's just a
Mhm.
whole lot of diverse restaurants that you have on Buford Highway. So I think those are probably some of the places to check out.
Does Buford Highway goes all the way into Atlanta?
Yes, it does. Yeah.
Wow. I clearly don't know a lot about Atlanta. But yeah, I agree. I don't think I've been to the zoo, but the Georgia Aquarium's definitely one of the biggest in the world. And then they say Centennial Park and Piedmont Park are nice places to just relax with events. But Midtown seems like the place one should definitely check out. Well, did you grow up playing sports at all, or did you?
Yeah, I played a little bit of soccer as well as ran track. Those are the two sports that I participated in high school.
Okay. If it had any impact, sports as a whole, how did that influence your decision to become a sports medicine doctor?
When I was participating in the sports, I didn't necessarily think it was gonna make me go that direction. I think my
Mhm.
interest in sports, my interest in biology, my interest in anatomy, my interest in physiology is what I kind of went the direction of. What
Mhm.
I enjoy so much about sports medicine is the teamwork components, the camaraderie components, the desire for athletes to be the best version of themselves. Oftentimes in other spheres of medicine, you don't always get that. But I think, what I practice in clinic, that's what they practice in sports, the teamwork, having
Yeah.
different group of folks working together to make a patient or athlete better. So I think what I enjoy about it is the desire for athletes to get better, practicing the same team spirits that they practice on the field, practicing that over here, and
Yeah.
just genuine love for sports anatomy is probably what got me into it.
Gotcha. Team. But I do have to say that the schooling is quite a bit. You do 4 years of medical school, then you complete a residency and postgraduate training. In total, how many years is that?
Yeah, I stopped counting my grades because I think I got up to like 27, 28 grade at some point in time.
Yeah.
You said, you finish 12th grade, you do 4 years, that's 16. Uh,
Uh-huh.
you do, for me, I did 6 years of postgraduate training after that. So 12 plus 4, 16 plus another 6. So maybe not 29, but you get the point.
Yes, yes.
It's I got up there in the 22nd, 23rd grade.
Your postgraduate training, obviously your focus is a lot more like in the orthobiologics, regenerative medicine. Was that postgraduate training more of that, or what exactly was that?
So usually the way it breaks down is you do a residency program and you do a
Mhm.
fellowship program. So I did a sports medicine fellowship. During my
Okay.
fellowship, because that was around 11 years ago, the word of orthobiologics, PRP, stem cell barely existed, just started.
Mm.
So during my sports medicine fellowship, what I kind of learned was more managing concussion, treating joints, dislocations, ankles, shoulders, knees, discussing the other aspects of sports medicine. I actually
Mhm.
started delving into orthobiologics as an attending, kind of reaching out and just finding out the different courses, different individuals that did a lot more of that. So it wasn't until I became an attending that I actually started dwelling or delving into orthobiologics proper.
Gotcha. Okay, that makes a lot more sense. Now, Dr. Olufade, before we get into avulsion injuries, just curious because I have been working on getting a number of surgeons on this podcast. We've been exchanging emails for months, but they're coming, but it's taking quite some time. But when I think about when I reach out to European doctors, for some odd reason, they don't seem to be, not that they don't work, but they don't seem to be as busy. I mean, you could just get a hold of them quickly. And I just feel like in America, like certainly there's such a demand for doctors regarding to obviously electronic documenting, productivity, all of these different standards. And I was reading an article and it was talking about how doctors actually spend more of their time completing clerical tasks, interfacing with the electronic health record. How accurate is that for you?
It's 100% accurate. So as a physician that
Mhm.
work at an academic institution to start with, the pillars of
Mhm.
medicine includes not just clinical, but it includes research and teaching as well. And so
Mhm.
if you start with that, three pillars, we understand that 100% of our time is not spent in clinical. There's also research and teaching. That's number one. So now that you break it down to the clinical level of things, you're right. It's probably only about 50% or less sometimes of the time that I spend on a patient's care do I spend in their presence. There's a part of which you look at the imaging studies. There's a part where you review some of the medical records. There's a part when you get out, you order some of the studies that you want to order and the completion of the notes. So I think you're right. I think a lot of times we're doing several other things, teaching, doing research, seeing patients. And even when you see the patients, a good portion of the time, you're not doing face-to-face. I think that's one part. And I think the second part is just, I think a lot of physicians are being pulled in other places as well, outside of some of the things that I mentioned.
Yeah. Now, are you sure every physician teaches? I mean, I don't know that every physician I've met, they tell me they're teaching at a university, but you do at Emory University. Give them a shout out.
No, you're right about that. I think the academic physician that I'm referring to. So, I could speak a little bit for myself. It's kind of hard to speak to other folks, but I think those are some of the things that makes it a little bit tricky for me personally.
Yeah.
I can't speak for others, but if I had to speculate, I think at the end of the day, I think people lean more towards where their passion is. My passion is with this and my passion is in this. So I think at the end of the day, if they're getting pulled in one or two other places, I choose to kind of lean more in the direction where my passion is.
Leaning to the direction where your passion is. But even if you lean to that direction where your passion is, I imagine that for a number of physicians, the overwhelming demand can sometimes impact the direct care of the patient. How do you ensure that, patient care is still the top priority despite getting pulled in different directions to do different roles, as you mentioned?
Yeah, I always tell my residents and medical students, as well as high school and college students that shadow or rotate with me, before I go see a patient, I review the records, I read this, I look at the x-rays, I do that. But right before I go into the room, I'm a clean slate. Mm-hmm. I listen and I've heard everything, but I let none of those I make sure they don't give me too much opinion of where I'm going into. So I think the openness to see each person as an individual. I think the really being able to relate with a patient and saying, if this was my brother, if this was my aunt, if this was my nanny, if this was my sister, how will I want to treat them? So I think what I do is I try to clean out all the rest of the noises, even though I review the records, to kind of get my own objective understanding of what's going on, and just trying to be able to say, what, I need to do the best thing for this particular in front of me, because at the end of the day, when I'm in that room, for whatever period it takes, that is my patience. Even though I tend to be a punctual person with everything, I do apologize sometimes when I'm late, because that person that needs that moment, if you don't give them that moment, it's something they're going to remember negatively. So I try to make sure I hold on to that.
Yeah, I like that. And I can speak from personal experience, because even when I came to shadow you, I felt like, I know you had a resident, you had other people, and I still felt like you were able to educate me, answer questions that I had. So I feel like you are definitely a special human being that is very generous with your time. Now, on to apophyseal injuries, which are injuries that are common in adolescents due to that growth plate. We aren't going to talk about all the injuries. Specifically, we're going to talk about the avulsion fractures, which you all presented on, not this year, 2022 at the Isokinetic Conference. We'll discuss at the end. But to first open it up, I want us to just first understand about this injury, and then we'll talk about that case study. So first question, why are adolescents at an increased risk for an avulsion injury?
Adolescents are usually at an increased rate for this avulsion injuries for multiple reasons. One is overuse. The amount of demand that they have on their body can be high. So, for example, we see it's not unusual to see folks playing 9, 10, 11 months a year. So the first is just that demand. The second is their body, the structures are not well matured enough. So if you have too much demand on the body that it's not able to give in or supply a lot of what it needs to, I think that will result into an issue as well. For an average person or older person, usually the tendon is the weak link. But in younger folks, it's that area where the growth plate is, the apophysis. That's where the weak link is. So those are some of the probably main reasons why they are more prone to having apophysitis and apophyseal injuries.
Yeah. And now as these kids are experiencing their growth spurt and we're seeing an increase in the body mass and the height, How can athletes be proactive in incorporating early strategies to possibly decrease their likelihood of sustaining this injury?
I think the first thing is sports specialization. So studies have been shown that the sooner you specialize in sports, playing the same type of sports for greater than 8 to 9 months a year, the more likely you are to injury. The idea is if you use other parts of your body, if you avoid that overuse of one specific area, as in kicking repetitively. So avoiding sports specialization till an older age, that's one of the ways to go about it. The second is a lot of times when this, especially the pelvic area, when the injuries happen, it happens between of this kicking motion that you have, making sure you have a balance between the hamstring and quadricep, making sure you have good flexibility and range of motion. I think those are some of the things that will decrease the risk of having these injuries.
Yeah. And you kind of jumped on the topic that I was going to actually ask you about with these avulsion injury of that inferior iliac spine along the pelvis. It involves that rectus femoris, which has that direct attachment. Now, you've already mentioned it, like the common mechanism is kicking. What do we see commonly leading up to that? Do you typically hear of athletes maybe suffering from whether it's a quad strain to get this injury, or at times you have athletes, they just come into the clinic, boom, they've had this injury?
I think most of the times it happens acutely without any previous injury. I think the numbers are about 9 to 1. 9 out of 10 folks that come in, it's an acute injury. They didn't have anything that happened before that. About 10% will be more of a re-injury, meaning they've had some kind of strain to that muscle a while ago, and they really never just allowed it to heal. They didn't do the proper rehabilitation, and that will re-injure itself. So the ratio is about 9 to 1. So most people, there will be just nothing that started it before. The acute injury occurs by itself.
Okay. So if one is suspecting, say it's a clinician that's suspecting this injury, what in an athlete's history, aside from, they kicked the ball, felt a sharp pain, had the pain along the front of the hip, what factors do you consider when they either call you or present in your office?
So when it first presents, a lot of times the main thing is that tenderness to bony prominence palpation. So if it's the ASIS or AIIS or the pubic symphysis, whatever it is, that point tenderness around the bone is the first thing that you will notice. A lot of times when I see these folks, either sideline or in the office, I use my ultrasound machine as well too. So sideline ultrasound machine, being able just to scan frontal palpation, you identify the area where they say that pain is, and you kind of lay the ultrasound probe on it. There's some characteristics of ultrasound that you'll see. Simply said, the bone is white, and you're going to see some increased black on top of the bone. And that's one of the things that will allow you to know that there's more apophyseal type injury that's going on. Sometimes they'll have some blue-black discoloration around that area. I always tell people, make sure you check for one joint proximally and one joint distally. So if it's the hip, go a little bit towards the abdomen area. If it's and make sure you examine the knee very briefly as well too. That way you don't get fooled by other injuries that could mimic that.
So when you say be sure to check the joint above and below, so when we talk about the abdomen, what are maybe some differential diagnosis considerations that could possibly be there?
So let's say, for example, it was a collision injury. You want to make sure you look for the lower abdominal quadrant area. Make sure you don't have a blunt trauma to the gut, to the abdomen, that's resulting to referred pay down, right? So let's say, for example, it's more around the quadricep muscles. It could be the proximal insertion or the distal insertion. You want to have an idea of where that type of injury is coming from. I think this applies to apophyseal injury, but I think that's just one of the things that always do. Go proximal distal. I can't tell you the amount of times I've seen patients that presents to me with knee pain, and you examine them, it's actually referred from the hip. I think it's always important to check one joint proximal and one joint distal.
Yeah. And with this type of injury, it may not necessarily even always present on the anterior hip. It could be more even on the inner thigh and sometimes posterior too.
Yeah. So when you start talking about the posterior, it's we call it about this deep gluteal pain syndrome. There are about 50 different things that could give you buttock and
Oh
glute,
yeah.
right? So you're right about that. So where is it coming from? Is it coming from intra-articular pathology? Is it coming from a extra-articular hip pathology? Is it coming from your back? There's so many variable things. So it's very important to make sure you have your pragmatic process in eliminating and differentiating and making sure you kind of touch all the bases. That way you don't miss anything.
Yeah. Now, say if a medical doctor or whoever's on the sideline may not have access to an ultrasound, why is it important that even if they can't pinpoint, okay, this is an avulsion injury, for them to take careful care of ensuring the athlete gets off safely and either protecting that joint from too much weight bearing early on?
Now, that's a very good point. The question is, a lot of times, most of the times, it could be a apophysis injury, but sometimes that's not the case, right? So I think just getting an idea, making sure they're stable, making sure neurovascular, they're intact, making sure the joint is actually in place. I think once you have that, you kind of get a sense if they're able to put a little bit of weight on it. If there's no open fracture, if there's neurovascular intact, if the joint is in place, more than likely, maybe with the help of a player or athletic trainer, you'll be able to get him to sideline. I think it's when it's sideline that you tend to evaluate more of the pain. That's when you get him into ice, you get into crutches, look at other things a little bit. Most of the folks that have this injury, they will end up needing crutches for a couple of weeks anyway, because they're just not going to be able to put a lot of weight on it. I think that's one of the things that's going to let you know, despite the ice that you put it in, crutches is the way to go. That way they're just not pounding that area that's pretty injured at this point.
Gotcha. And you talked about being able to use the ultrasound on the field, but when you're then making the diagnosis, say the athlete goes into the clinic, if you've done the ultrasound, are you doing further imaging like an x-ray to confirm that? What more are you going to order?
Sideline, you could use that, but definitely when you see them in the clinic, radiographs and x-rays is a standard of care. You have to get that x-ray. So that's kind of what allows you to see if there's just apophysitis or if it's a apophyseal fracture, which is a separation of a fragment from the apophysis, and will allow you to, quite frankly, measure how much retraction that you might have from the site of the fracture. So I think ultrasound is for sideline, but when you go into the office, you use the ultrasound as well too, but x-ray is one of the standard of care as well. Every now and then, if you cannot or if you're not clear, then you might get an advanced imaging study such as an MRI.
And going back to, you were talking about the amount of displacement, you can actually see that on that x-ray, or is that more on the MRI?
You can see that on the x-ray. You can see that on the x-ray. A lot of times, depending on how much separation or retraction there is, you will probably get an MRI just to kind of check on some other structures, but you could see it on the x-ray for sure.
And you said the MRI to check on some other structures. Are we referring to maybe some extra articular structures, or if we're suspecting the labrum, is that when you would get an MRI?
Oh, these are all extra articular structures that I'm referring to.
Okay.
A lot of times you want to just check for the soft tissue part, look at the muscles, look at the tendons a little bit more, just to get some clarity to make sure that there's nothing else going on. That's when I'll get the MRI.
Now, CT, obviously not the best of choice due to radiation exposure, but if you had to use it, if you have to, when do you use that?
A lot of times I don't find CT scans to be helpful in this situation because what the x-ray is not showing is soft tissue. That's where you can get some from ultrasound, and whatever you're not getting from ultrasound, you will get it from MRI. I can't remember a time where I would really get that. Obviously, if you're concerned about heterotrophic ossification, which is just accumulation of bone, frankly, and you don't see it as well on the x-rays, in those rare situations, you could probably get a CAT scan, but that's not something that I routinely do at all.
Okay. And then what about like possible like impingement? Do you commonly see that presenting with an avulsion fraction, like if you're suspecting a little bit of impingement going on?
Now, you raise a good point, because I think one of the question is, when do you have to treat apophyseal injury non-operatively, as well as when do you refer it surgically? A lot of times, if people are having, despite crutches, despite rest, despite physical therapy, if they still have extra-articular impingements with prolonged sitting, those might be one of the scenarios where you'll say, you know what, it's probably best to go for surgical evaluation to try to fix it because you've tried all of those. So there tends to be a lot more extra-articular impingements and not intra-articular impingements in this type of scenario.
And why is that? I'm just curious. Do you feel that avulsion fracture led to the extra-articular impingement? What actually, if that makes sense?
Right. The way to think about it, so if you think about the location of the rectors, the indirect head of the rectors femoris coming to the AIIS, right? If you're sitting down, especially with seated, there's going to be a little bit of abutment and pinching of that tendon or the loose components of Volst area is going to be kind of bumping a little bit, especially when your hip is about flexed about 90 degrees.
Yeah.
So it's more of the position that you're going when you're in a seated position or hip flexion. That's more of what results into that impingement. If you're standing and doing regular stuff, you might not have too much of that.
So that means for our listeners, impingement doesn't necessarily mean that you have had this when you were young, anatomical, you were born with it. Actually can result after an injury like this. Well, just as you mentioned, it seems that conservative treatment seems to be pretty effective in addressing this type of injury. And I believe they said the mean return to sport was about 2.9 months compared to surgical intervention, which was roughly 6 months. Obviously, there's not a ton of literature, but there are some systematic reviews. But how do you determine if one would actually be a candidate for conservative treatment? Because from hearing you, certainly you said that that's where we start off, but is it every athlete that you might consider conservative, or are you going to make that judgment based off of the displacement?
So I think one is apophysitis injury versus apophyseal fracture, right? So for
fracture
type components, they're going to be non-operative management. For the fractured ones, I think there are a couple of things to keep in mind. One is the degree of the retraction or separation. And so the degree of displacement is number one. And the second we use is just, even if you try to treat it non-operatively and they're not doing well, then that's another indication where you have to consider surgical evaluation. If you've treated them for several months, they're not getting better, then you want to recommend. So degree of separation or displacement, if they fail non-operative treatments, will probably be the top two, as well as if they having repetitive impingements, even with treatments. Those are probably the three criteria that I use.
So from a doctor's standpoint, what educational insights can we give these athletes and families about this injury, avulsion fractures? Because obviously later on, we're going to talk about your case study, which is actually fairly unique because it kind of goes against what the literature says. But how can we educate athletes and families to maybe understand how this process can evolve to make sure that the athlete not only gets back to their sport, but make sure that we're not risking a re-injury or anything like that?
I think one thing to keep in mind is at the end of the day, if your athlete or your son or your daughter cannot put weight on their leg, I think it's always a good idea to get crutches and have them see a medical provider, i.e. a sports medicine physician. So the inability to put weight on your leg is one of the things to keep in mind. The second thing a lot of times is if you start having blue-black discoloration, that might not even happen on the day of injury. It might take a couple of days to happen. If you start seeing blue-black discoloration around that area, that's also another sign that there's something else going on. The third is, let's say, for example, John hurt the hip and, they never went to the doctor's office, they never went to the pediatrician. If they still given a few days and they're still not getting better or things are getting worse, that's another idea. And this whole concept about just instability, they just don't feel stable. They feel like they're going to collapse. They feel like they're going to fall down. If they're having a lot of repetitive clicking and catching and snapping sensation, that's also giving pain. I think those are probably some of the indications to say, you know what, I should probably go see a doctor for this and get this checked out.
And when they see a doctor, as you mentioned, they may start off, partial weight bearing for some weeks and then obviously progress to full weight bearing. What factors do you consider when you're advising an athlete to progress to full weight bearing? Or is this something that you allow either the physical therapist to make that decision?
A lot of times I use several things. Usually I'll get a repeat radiograph to kind of take a look, make sure things are not getting worse. If I have the confidence, so most of the time if they have a avulsion fracture, I'm probably going to put them on crutches for at least 2 weeks and bring them back. I'll get a repeat x-ray and to see, make sure there's no widening or worsening of the displacement. If it's not and the pain is better and they're able to put some weight on it, I might go from 2 crutches to 1 crutch and see how they feel. And once they feel okay with that, we'll get rid of the crutches completely. Definitely seeing what the physical therapist is doing and the prolonged period of time that a therapist spent with the athlete will let them also give us some additional information to say it's actually okay to kind of have full weight bearing without crutches and without any assisted device.
And in what cases do you find that it starts to widen? Is it, why do we, like, I mean, I'm sure you might have had these cases. What may cause that?
I think there are 2 possibilities or several possibilities, but the first 2 to keep in mind is this. All right, you tell Michelle, okay, you have a fracture. I don't want you to play soccer anymore. I don't want you to kick anymore. Michelle goes sideline, is hanging out by the side, the ball is coming away, and she's like, you know what? I could kick the ball back. That's not gonna hurt. So re-aggravating a re-injury will be number 1. The second is sometimes if you see a player in the acute state of the injury, the fracture is actually not settled down yet. It's so fresh. There's so much muscular spasm component to things. So the level or the degree of displacement is not showing its true color yet. Sometimes it just take a couple of days to actually see the true characteristic and quality of that fracture. So those would be the top 2 things.
Okay. And we won't go into detail about the treatment, but when we do talk about at least returning to the sport, it's important to understand the prognosis. So obviously understanding the anatomic location, the cross-sectional involvement, as well as if there's any fluid. But specifically, when we talk about the anterior inferior iliac spine, that avulsion fracture there, how does this location impact the prognosis compared to, say, maybe a mid rectus femoris strain?
So a lot of times when you had a strain of the mid rectus femoris, most people can actually put some weight on it and walk on it after a few days or so after that injury occurs. So a lot of times when you have a muscle strain, you could have a little bit of ecchymosis. You can have some collection of blood that's present over there, but there's no significant widening of the muscle group. And so because it's not at the points of insertion or origin, it tends to rehab and heal a little bit faster. So that's more of a muscular issue versus when talking about apophyseal injury, that's actually more on the bone. So muscle type injuries, even though they could linger a little bit more, their rehabilitation course sometimes is a little bit easier to predict, I will say. Since if you have a avulsion fracture, it just limits you a lot and you're not going to be able to do most of what you want to do. Versus if it's muscular in nature, you could still play through some pain, even though you're not going to be 100%.
Right. Yeah. And in this systematic review, I'm blanking out on the name of it, but it's one of the few ones on these avulsion injuries. They found that the proximal tendon injuries with greater than 50% cross-sectional involvement and involved some fluid are associated with a longer return to sport. So when we talk about kicking, because this is a common repetitive activity involved in soccer, why is it important to delay that a little longer for these athletes that are just coming back from an avulsion fracture?
Yeah, I think when you think about soccer in general, I think one of the things we do is we forget about just the pathophysiology and the healing capabilities in general. We tend to rush people back to the sport, and that's why we have a high rate of re-injury, because we just don't allow enough rehab or allow enough of those structures to heal. I think your point is 100% correct. I think rushing an athlete with this type of injury is just understanding that they're going to be back on the sidelines again very soon. I think depending on what location the avulsion fracture is, they vary a little bit. The lesser trochanter are a little bit different from ASIS, a little bit different from AIIS, but understanding that, I think you just got to rehab them, look at what the number shows, have an average of how long it's supposed to take. Make sure you measure the strength of the ipsilateral or the contralateral limb. Make sure they're similar and just slowly get them back into that return to play is extremely important because if you don't do it, they're going to come back and be injured again.
Yeah. And certainly every athlete is different. Every athlete has their own unique case. And just like you mentioned, depends on the location, how much of the extent. But from reading some of the case studies, some of the literature, it does seem a number of athletes return to their sport. I mean, at minimum, like 10 to 12 weeks. For you, is there a minimum time frame that you give every athlete, regardless, to ensure that you are decreasing that chance of either a refracture or a re-injury or tendon retraction there?
I will reiterate, I think it really, really depends on the location. I think some avulsion fractures will heal within 6 to 8 weeks, while some
Okay.
10 to 12 weeks. So it's actually a little wide range. So I don't group them all together.
Yeah.
I treat the individual depending on what location it is. So the individuals, the type of sport they play, the location of fracture. But at the end of the day, just making sure they don't have pain anymore with while they're using crutches, translate them to walking by themselves, making sure you start their rehab, making sure you're able to work through some of the muscular imbalances that probably could have resulted into that. I think that's kind of what I use, just a gentle return to play protocol. And I try not to abide. I use the guidelines of timeline as guidelines, which is what they really are. And I usually try to treat the patient specifically based on what the particular needs are.
So you've had an athlete that was able to kind of return back full participation within 6 weeks or so?
6 to 8 weeks. I
Okay.
don't remember exactly, but yes, we've had definitely a couple of those.
Okay. Now, going back to the athletes that may return early, what are some complications that you have seen? Like, have you seen that maybe they re-injure other structures or anything like that?
Yeah, one of the big risks with this type of injury, like I mentioned earlier, is atherotrophic ossification. So when you injure that type of location, your body just notices the injury and it's just trying to heal it. And it could lay a little bit too much bone, a little bit too much calcium deposits. So I've seen a couple of situations where they just grow this increased amount of calcification around that area. So I think that's one thing that's potential can happen. So if you have an athlete that you're treating and it's not getting better, I think those are the reasons to bring him back in, get some repeat x-rays, make sure there's nothing additional that's going on, because those are kind of one of the complications that you could have as a result of that.
And do you often see anything with the labrum at all as much or not so much?
When we think about this is all extra-articular type injuries. Obviously, if you find something different, the question now becomes, if you see something in the labrum, are they actually symptomatic or asymptomatic?
Right.
Is it an injury or not? Or else I have a strong reason to look through the labrum based on my exam. That's not something that I usually look for. I mean, I'll examine them, but I've not seen any strong correlation between the two.
All right. Well, we're going to get right into your case study. I don't want to leave any names out, but your team presented, it was about how displaces to displace an avulsion fracture in an adolescent footballer. Pasculi, Troyer, and Olufade were all of the participants, and I'm sure there's many more that I might have missed. But just to summarize this case study for our listeners, so obviously correct me if I misspeak on anything, but it was an athlete who had an avulsion fracture of the AIIS. Y'all did an MRI of the right hip without contrast, confirmed an 8mm by 27mm avulsion fracture from the rectus femoris attachment to the anterior inferior iliac spine, distal displacement of the fragment by 36mm. Now, giving that amount of displacement, y'all's recommendation was possibly to consider surgery. The family wanted to do conservative. So you had the athlete progress from partial to full weight bearing as tolerated, completing PT with the focus of strengthening sport-specific tasks for 6 weeks. After his injury, you had a 2-month follow-up, cleared to play football and do some modified kicking. Then by 3 months, he reported to be at 90% with mild intermittent right groin pain during practice. And then y'all did note that the x-ray showed increased ossification of the displaced bony fragment, but he was able to successfully return to his sport at his prior level. So my first question with this case study is, what surprised you most about this case? Because based off of the guidelines of surgery recommendations, this is an outlier, right?
Right. In terms of what the displacement is, 20 minutes is what the guideline is. I think what's different about this case is it was almost twice the amount in terms of the degree of retraction. I think that's one of the things that was unique with this. And that's kind of one of the things that we wanted to suggest in the literature, that is actually possible to have a little bit wider separation and still be able to be treated non-operative.
So when you say that he returned to a sport at his prior level, do we have any idea how close was he to get to 100%, and at what time frame? Was that after 3 months?
So that was after three
It
months.
looks like.
Yeah, that was after 3 months. And I think that's kind of where you have to kind of rely to some degree on what the athletic trainer at school tells us, since they're the one that's supervising and watching over them, what the parents mentioned, and as well as what the players said. For this particular player, we didn't have any specific objective data. It's more of just the word of the athletic trainer, parents, as well as the player.
And so how often were you doing the imaging? Because I imagine you still wanted to have an idea of, right, how the displacement, is it getting smaller? How often were y'all doing that?
So we probably got a total of 3 or 4 X-rays within the span of 3 months that I saw him. I'm not gonna get X-rays if the athlete is doing well and everything is going well. The purpose of the X-rays, the first couple of times after the injury, I want to assess things. So if a athlete is doing well and is or she is able to return to everything, I'm not going to get serial X-rays just to continue to check on the fracture, because it's irrelevant for the most part at that point.
So even if that displacement didn't get significant or wasn't cut in half, really it's functionally how they're doing, it's going to be the major determining factor?
Yes, because a lot of times you're not going to have a full union of the displacements from the origin where it occurred, right? So you just want to try to see if everything was scarred down and healed by itself. I always tell people, we treat the athlete or the patient. We're not treating the imaging study, and I feel strongly about that. So, and as you could see in a lot of other literatures, even when you try to predict return to play of an hamstring injury by using the MRI characteristic, that does not always pan out. So that's
and going back to the union, so it's surgery for sure if it was obviously full, right? But in its case, this is not a full where it's completely disrupted, right?
That is correct. That is correct.
Yeah. Okay. So obviously, despite y'all's recommendations, what about this case do you think allowed this athlete to return to sport at greater than 90%, or at least 90% within 2 months? Is there a way that this avulsion fracture presented that was to his advantage compared to maybe a different direction?
I think the AIIS one is the most common avulsion fracture that you could have, especially on the pelvic area. So I think there's just a little bit more information and knowledge on this. We know that this kind of tends to heal a little bit better based on the location versus, for example, if the lesser trochanter that you're dealing with, that tends to take a little bit longer. So the nature of the injury, I think that's one. I think the second is just knowing the family and the athlete that you're dealing with, making sure it's somebody that's going to be compliant with your recommendation. Because if they're not compliant, then they're probably not going to get better and not get better that quickly. So I think those are the top 2 things that stands out to me.
And for that family, because like we talked about before, re-injury, especially those early weeks, are always a concern. What did you educate their family on, especially when it came to him actually getting reacclimated to his sport, or soccer, which is what he played?
Yeah, I think what's unique about it, he actually had a similar injury at that location about a year ago. And so I think in his head, he's lived through what playing through the pain could be like and what are the consequences of that. Because the reality is there's probably some degeneration, some overuse that's happened around that site. I think getting him to buy into what's happened before, the reason why we need to rehab it well, that way you don't end up in this situation. So getting that athlete's buy-in is extremely important. I think having a good relationship with athletic trainer at school as well, too, who's going to be able to kind of keep an eye on him or her, kind of give us some feedback on things, how things are going, and, you know, being able to kind of check on them during injury clinic or whatever sport that I'm going to kind of cover at the school. I think that just having that communication is essential and important too.
The ones that go the non-surgical route that have that avulsion fracture, especially this athlete particularly, he had it in the past and then he had it now. What are the recommendations that you may give him? Certainly, physical therapists, we're going to be giving our recommendations on kind of the rehab component, but regarding to his prognosis, his ability to fully participate at a high level.
Yeah. So a lot of times, especially teenagers in general, they're very, very tight quads, hamstring, and stuff like that. That's not what most of them want to hear. But if mom was with them, I just say when mom is going for yoga Pilates, just go try a couple of those classes and just see how it goes. So I think flexibility, range of motion, making sure we're not overloading things. Those are probably the top things that I mentioned to them. Get that range of motion, get that flexibility, get strong in other parts that are weak right now. Those are probably the main things that I mentioned to them.
Okay. So do you have any concerns oftentimes? Like this case is pretty unique, but if it was, I mean, even if it was larger than what was it? Did we say 36?
Well,
I mean, if we're talking 40, like as a sports medicine doctor at times, so even though this case was successful fairly, do you actually have some concerns sometimes with these athletes that are like, I'm open to both routes, but I'm not sure? Like,
yeah, a lot of times what I would do is I will have a surgical consult as well. I'll have a conversation with my surgical colleagues to get a an opinion from them. And a lot of times we don't make this decision in isolation. We'd sit down as a group, or we kind of exchange some conversations, and we'll say, you know what, there's a good chance this will heal by itself. I think it's worthwhile trying non-operative route. If for whatsoever reason it's not, that's something to always consider in the future. So to answer your question, I think it's just having a multidisciplinary approach, being able to have other folks to bounce ideas with and have those conversations, and also figure out what the goals of the athlete is, what time of the season this is. If they were supposed to still have surgery done, do they have time in the future to kind of consider that? Those are some of the things that I use.
but if this athlete does have this injury during the season, it's still a matter. I mean, if they're in pain, it's probably not going to be him going back to the pitch, right?
He's going to be out anyway for the most
Yeah.
part. It's just a group decision. Some folks lean one direction or the other. I think I just given the pros and cons and the reason why we're leaning one direction or the other. And I tend to kind of make that decision as a group and not necessarily dictating or mandating that this is what you have to do.
Yeah. So at any point though, even if they said they had minimal discomfort, they're obviously working with their therapist, or minimal pain, and they're in season, is this something that they could actually play? Like say if they have just 4 weeks left of the season and they're reporting just minimal pain, are they at risk of doing like really serious damage, or do you kind of again give them their options and let them decide, or do you just say just call it off?
With this type of injuries, we have the conversation about what the treatment is going to be initially, but I'm not going to let them go back and play if they're not 100% ready.
Okay. So yeah. So not experiencing pain then, pretty much.
Not just pain though. So for example, I'm working with a kid that just had an ACL surgery about 18 months ago, and he stopped having pain, but significant atrophy of the legs, not able to have the strength. So I think pain is one portion, but I think making sure we have some symmetry in the strength as well amongst the things, and just being able to do sports specific drills comfortably. So I think all of that plays a role in addition to pain.
But I guess I'm curious though, say they can do all of that, but they have pain. Would that still be a no-go?
It depends on the degree of the pain they have. If they tell me they're having some soreness just because they've not played in a while, I'll be okay with that. If they say after 3 to 4 weeks of them trying to get back to playing, they're still having pain from the very basic things, and it's not necessary soreness, then that's when we start getting repeat x-rays. That's when we start considering maybe advanced imaging study just to make sure nothing has gotten worse.
Gotcha. So this case study goes to show certainly clinical experience is there. There's systematic reviews, but case studies still have a role in medicine for clinicians, especially early clinicians that are exposed to maybe a rare injury like this. What advice could you give regarding to their thought process and also their mind when it comes to not keeping such a closed mind when dealing with maybe a rare injury in one of these athletes?
I think it's always good to support yourself with a good team, have colleagues that you can reach out to to have conversations, sometimes debates in terms of the best way to go about things. So the first thing is just be resourceful and have folks that you feel comfortable talking to. I think the second is just making sure you're able to meet that athlete at the point of where they are. Sometimes you talk to certain athletes and they just feel comfortable with you and they'll tell you, Doc, what would you do? And I'll tell them with the information that I know, I would do X, Y, and Z. And just not be shy to ask for help whenever you need the help. Those will probably be my top recommendations.
And then when it comes to educating athletes, sometimes about, and families, let's say this because the athlete, it's a whole team, the coaches. When it comes to some of these injuries that may not have as much data, and just like we talked about, we could be talking about a hamstring injury, that recovery could be wide varying from weeks to months. There's no concrete 6 weeks, one's going to be back. What's been the most challenging, if there's anything challenging, when it comes to giving these athletes a prognosis? Maybe they don't want to hear, but at least laying it down for them, whether it's 2 weeks, 6 weeks. What's most challenging for you when it comes to these ones where we just don't have enough data and it just presents so differently?
I think most athletes, especially at high school and college and professionals, they hear some of what you say about the injury, but what they really want to hear is, Doc, when am I going to go back to sports? And so you could say a lot of words, but that's what they really care about. That's what they really want to know. And I think for me, it's just trying to give them that range. And when I give them the range, I'm going to give them the latter end of the range. That way, if it's, a 6 to 8 week situation, I'm going to say 8 weeks. So if they better is 6 weeks and they're able to return, fantastic. But if you tell them, 6 weeks and it's the 7th week or 6 weeks, they're not ready. So I think the tricky part is just setting expectations and sometimes just say, you know what, I cannot say it's going to be 6 weeks. I think 6 to 8 weeks it is. I think just having a little bit of flexibility in terms of the return, as well as just leaning on the latter end of the time and not earlier. Those would be some of the tricky parts of it.
Now, I have to say, like I mentioned earlier in this podcast, you're so available and very generous with your time. And I remember when I was in Arizona getting ready to make the transition to Georgia, I think I'd reached out to you about like just some research, and you were giving me insight. Yeah, when you get here, definitely let me know. And it just seems you really enjoy what you do. What gives you the most fulfillment about your job role today?
I think there's several folds. I think right now, I have 2 high schools that are shadowing me. And sometimes it's not always the convenient thing. But I remember when I was a high school student, I'll be so excited to have this opportunity that they have. I had a college student a few months ago that spent some time with me, spent about a month, and he learned a lot of clinical stuff from me. But he mentioned at the end of the rotation that he learns lifelong lessons from me. And I think at the end of the day, I just remember myself being a kid in high school and college that was a little bit lost, quite frankly, that wasn't sure what to do. I think having anybody that could give you a minute or 10 minutes of their time to kind of help you with that direction. I think when I look back, when it's not the convenient thing to do, when it's not the comfortable thing to do, that's why I do it. I think medicine is just it's just part of who I am, meaning who I am should exude regardless of what else I do. So I just try to stay grounded and remember those things in terms of where I came from, how I grew up, some of the uncertainties that I have, and I would like to continue to impact that in other folks. Those are some of the reasons. And quite frankly, I enjoy it. Some will say I'm a people person. I think I am most of the time.
I think you are.
So I think that also helps as well, too. It's not as much of a burden. It's not as much of a work. It can be work, but it doesn't always feel that way.
Yeah. I like what you mentioned about lifelong lessons. And for you, I'm sure you've had some instrumental people that have crossed paths with you. What's an early lifelong lesson that you maybe learned early when you were a sports physician that you continually incorporate in your day-to-day today?
It's important to not be in a shell, not to be in a bubble. I think it's important to try to stay in contact, have your village, have your team, have people that you could reach out to. Don't be shy don't be shy to say the group that I'm going to have to look just like X, Y, and Z. Be open in your mind as well, too, and be willing to talk to anybody and everybody. try to listen a little bit more. Then we could all listen a little bit more than we talk. So the whole notion, try to listen a little bit more and talk less. That way you can kind of get some of the pearls that other people will have. And just believe in yourself. Believe in yourself. I think in life we're all going to go through certain obstacles. I think that desire, the belief, there's nobody else that could take away from you if you believe in yourself. And I think that's what part of the mentoring is, to support and help people believe in themselves about what they want to do.
I like that. I like that. Well, finally, what's next for you? You're sports medicine physician at Emory. You work with numerous teams from Atlanta Hawks, U.S. Soccer, a number of high schools. What other things do you got going on? Any research projects?
Yeah, we're always doing some research, just doing projects. I'm heavily involved in some leadership processes as well in different organizations that I am. So I think that's kind of taken some of my time. Research, and from a research standpoint, we're working a couple of manuscripts now. One of them specifically is to see, some people will argue that PRP doesn't work. I think most people that have that information knows that PRP works. And so the next question is, if you help an athlete return to play sooner or earlier, what is the timeline? Some studies have shown that, NFL player that has a PRP to the hamstring, they get back to playing one game earlier. So the goal now is to kind of figure out what is actually the improvements and return to play. Is it by days? Is it by number of games? There's a manuscript that we're writing on that to be able to summarize PRP and return to play. What's the benefit there is? I think that's one of the ones we're working on right now.
Oh, and PRP, it's pretty limited in the research too, right?
It's not limited. It's actually tons of it. It's more the uniformity amongst the type of PRP that's being used. That's probably so. Some people use autologous blood and just get 10 cc's of blood and call it PRP, or think they're going to get the same products compared to somebody that's getting 60 cc's. So I think the lack of uniformity is kind of at this point.
I see. Okay. Well, thank you so much for your time, Dr. Olufade. Are you going to be at Isokinetic Conference next year? Because I'll be there in Spain. I missed out this year, but I'll be there next year. What about you?
Yeah, I missed it. I missed out of it this year too, but I'm looking forward to being there next year as well too, and hopefully presenting a couple of cases again.
Well, nice. Well, if I don't see you before then, I will see you there, and hopefully you will not have any flight issues.
Remember that. I'll keep that in mind. Thank you.
Thank you so much for your time. I appreciate it. Well, thank you so much for tuning into the episode with Dr. Olufade. I hope you learned some things about avulsion injuries, as I certainly did myself. Now, don't forget to rate, share, and make sure you come back because, like I say it all the time, more content is coming your way.